Yeah, and so yeah, making sure that they are safe. We talked about the NPO, like gag reflex, that kind of thing. They're gonna be cold, all of that stuff. Okay, all right. If I say, let's skip that one. Skip that one. All right, skipping that one. Trying to see. Sorry, I'm trying to find. Okay, let's talk about atrial fibrillation. What comes to mind when you think about atrial fibrillation?
Yeah,
disorganized rhythm of atrial contractions.
That's right. And what is it?
Coagulation issue.
Yes,
Blood
correct.
getting stuck and not moving out of the atrium.
Exactly. So what is one of our biggest problems with this?
Well, coagulation.
Coagulation. Yeah. So they might form clots.
Stroke.
And we can have a stroke. Definitely. We can have a heart attack. We can have a lot of things. But what are we going to do for them?
Give them anticoagulation,
Anticoagulation.
Oh, like cardiovert them?
The defibrillator.
Well, cardiovert. We're gonna do cardioversion, not defibrillator. Right. So hold on. Wait. I'm trying to find the slide that says. Hold on, guys.
Actually, that's a good question. I'm gonna answer that.
Hold on, guys. Give me one moment. I thought I already had it up. Now I gotta
Keep.
What? Pain? What's pain? Pain means
hold on. Almost there. There's two. I'm looking for one. Here we go. Okay. So just want to stay to what I had given to you.
Is that coffee?
Say it again. Okay, right. So cardioversion, and if it's stable, we're doing anticoagulants. And if it's unstable, we're doing cardioversion, right? But if it's a lot, then we do what? We do the ablation, right? If it happens too much. Go ahead, On.
So on the exam, I know you cannot tell us, but if I read the questions, right? How do I know? Oh, is this patient having stable AFib or
It says it. It says it. It says stable patient, unstable patient.
Oh, okay.
Yeah.
It
should anyway. It should. Yeah. So we're definitely right. So we're definitely going to do a cardioversion, right? And we're going to do ablations. Yeah. Okay. Next one. And yes, you're definitely worried about the blood clots. So we're doing aspirin, Plavix, Lovenox, warfarin, whatever, if they're in the hospital that they need to be on to keep them from clotting. And let's see, what's the next thing that I want to cover? Okay, if I say pulseless electrical activity, what are we talking about there?
We're still confused about that. Is it the same as systole?
That is the same as a systole, yes.
Okay, so CPR, epinephrine, no shock, not shockable.
So it's not shockable, but that doesn't mean you don't shock, right? And I know that's weird because remember, we're nurses. We don't determine not to give patients care. Do you see what I mean? So we know it's a non-shockable rhythm, but if the person gets into a systole, we're still going to give them care, right? So if they have to, like if we come upon them and we're gonna put the AED, it's gonna, say, if the AED says, no shock advised, then we're not shocking. Do you see my point?
Yeah.
Yeah. So as a nurse, you don't determine when you stop CPR, when you don't shock a patient, when you don't do this. We know it's not a shockable rhythm, but we're going to go through the motions as if we didn't know, right? Because, and I gave this example as when I was in the nursing home, right? Most of our patients, God forbid, when they pass away, they do it within the night. And if they don't, it's every hour check, right? So if it took them an hour to find the patient and the patient died, let's say 15 minutes after they left the room. So that's 45 minutes that the patient died. So by the time we get to them, they're dead, right? But I can't be like, oh, he's been dead for who knows how long. He's cold, so I'm not going to do anything. He's not breathing, so I'm not. No, I have to put on the AED. I have to do CPR. I have to do everything. The EMT has to come into the room, find me doing compressions, the AED attach, because then if it's not there, they're going to say, I intentionally killed this patient, right? I did not provide care. Unless it says you their DNI, DNR, that's the only reason that you should not initiate care. Do you guys get that?
Wait, so on the exam, right? If there's a question that patient has asystole or PEA, and there's options are CPR, epinephrine, B is like shock them, C is like call a doctor.
Well, in that order, you would do CPR, wouldn't you?
Yeah, so we prioritize CPR and epinephrine over the shock, right?
Yeah.
Okay.
Yeah,
Yes.
because you know that their heart is not beating, so you want to start CPR. And if you're doing CPR, then we know CPR, BLS includes CPR and AED, like that. They go together. You don't do CPR without calling for the AED to connect it, right?
Not questions. If I say questions like, okay, patients, you're at the nursing station, patient go flatline, and there are like two options. For the four options, right? The first option is assess the patient. B is like CPR, epinephrine. C will be like shock them. D is call the doctor. I would go with assess them first, right? We always want to see.
So
would use
remember
CPR.
I said you have to read the question. If in the question there is an assessment, if they tell you the patient is not breathing, your patient is on the floor unresponsive, that is an assessment. So no, you're not going to assess. If you find a patient not breathing, you're going to start with what? CPR. Giving them oxygen. That's what you're going to start as, because that is an assessment. If I come in, right? If I come in and I see, just think about on a regular day, you walk down the street and you see someone goes, right? And they're holding their, like, right? If they're holding their throat, right? You're going to be like, you know, are you choking? Yeah, you're going to ask them. But obviously, if they look like they're choking, then you're going to start. You're not going to be like, let me get your finger. Let me see how much oxygen you're like. You're going to do something because you're seeing with your eyes what the assessment would give you. Now, if you come into the room and, you know, they tell you the patient called for help, right? Because she is feeling anxious. Now that is a term that's so fluid and so ambiguous, you don't know why. That's when you're going to assess, when the question doesn't give you what the problem is. Does that make sense?
Yes. I'm sorry. But yes, that makes sense.
Yeah, so if the question gives you assessment, you know, person's not breathing, person is turning blue, person is pulseless, that's an assessment. Someone did it for you and it's written there. They're telling you, what do you do next? And the next intervention is, if I don't want the person to die, is I have to do an action. And it's either give oxygen, do CPR, hook them up to something, right? And then I call the doctor to let them know this is happening. This is how I found the patient was blue, unresponsive, pulseless, and I turned the oxygen on. I started CPR. What do you want me to do next? That would be the conversation you would have to do with the doctor. But if the patient had anxiety, not feeling well, you know, I have a stomach ache, I have chest pains. Like chest pains could be diaphragmatic, ulcerative, it could be indigestion, it could be a heart attack, like I don't know. The things that are ambiguous, I don't know. That's when I have to go and assess. Okay. All right, so let's
Question real quick. When it comes to asystole, do we care about the ABC thing? Like if between oxygen and CPR, epinephrine, which one do you prioritize more? The oxygen?
So asystole, you start CPR.
Okay, period.
Yeah. Because if they're pulseless, that right? If it's, because usually if they're pulses, they're possibly not breathing, but I'd have to check on that to make sure. Because if your heart stops beating, then you're not going to be breathing because the oxygen is not going to bring it to your brain, that kind of thing. So yeah, so CPR is what your priority is going to be. Okay, let's see, next thing. If I say hyperlipidemia, what comes to mind?
Me. We have a lot of fat in the blood, so high risk for atherosclerosis, PAD.
Okay, hold on, let me see our chat. Oh my goodness, sorry guys. Call code. Does the PE look similar to asystole? Yes, it does. It is the same thing. Could be very fine VFib. Yes, that is true. That was the last one. Okay, that's true. So we don't know if it's asystole or if it's very fine. So very fine could really lead to AFib there. Systole there. Sorry guys, I missed the chats. Give epinephrine automatically for asystole. Are we giving epinephrine automatically? So for asystole, we're doing CPR, okay? Are we administering when the doctor says to administer? If the doctor tells you to administer, whatever he says, you do, but you're gonna start with CPR. Okay, yep, cholesterol has to do with hyperlipidemia. So when we think of cholesterol, what other things? Yes, risk for hypertension, risk for PAD, definitely. Okay, so those are the things that come to mind. Sedentary lifestyle, atherosclerosis, building of plaque in the arteries that can affect your coronary arteries, that kind of thing. What else can we do? How about if I say sawtooth, what comes to mind?
Oh, flutter.
Flutter. Yes, atrial flutter, right? Yep, atrial flutter. That's right. And we're doing what again for atrial flutter?
However, it's the same as AFib.
Stable, you give
Yeah.
coagulants.
It was stable in BBCCB.
But which one is worse?
Unstable, right? Unstable is.
Right, the fibrillation is worse than the flutter.
Oh, I didn't know that's what you're asking.
Fibrillation is worse. Any fibrillation is worse, right? So when we have VFib, that's really bad, right? So AFib is also bad. Okay, when we think of P wave, what's P wave?
Atrial depolarization.
Exactly, which is the contraction, right, of the atria. Yep, atrial depolarization, okay? If it's gone, what does that tell us? If it's not there?
Ventricular issues. Perhaps there's a ventricular issues going
It's
on.
possible ventricular issue. Yep, all right.
Like VTAC, VFib, we don't see that. PVC, we don't see that.
Can you repeat that last part? You said when what's gone?
If we don't see a P wave in an EKG, we usually think that there's a ventricular issue, right? Because usually P wave issues, there is a P wave. It's just, it's a lot of them, or it comes too soon. But with ventricular issues, then we don't see our P wave. We just see wide and bizarre QRS. So if a P wave is on, then it's usually a ventricular issue.
Except SVT, right? SVT.
Yes,
like-
Is it because the ventricular issue covers the P waves in most cases?
So it's usually because, to be honest, I'm not exactly sure why, but I know that because the ventricular is more, when it's damaged, it's more problematic. So then it just affects the atrium much more than if the atrial has a problem. But I'm not exactly sure like the mechanism behind why it affects the atria, just because ventricular issues are just that bad. Yeah. How about if I mention preload? What is preload?
The amount of blood in the ventricle at the end of the diastole.
That's
Yeah,
correct.
I just said that. I feel so smart.
Good job. And furosemide, when do we give that? And what is it?
Loop diuretic. Loop give it for
High blood
hypertension.
pressure?
Yes, so when you have edema, says Nina, when you have high blood pressure, edema, says Su Young, CHF, yes, that's true, Melissa, right? And now what is the difference? What does it do exactly? Other than like, how does it relieve the fluid? Like, what is the mechanism? Diurese, right? It affects
It affects,
what
it
does,
affects the stop like the reabsorptions of water. So push all the potassium out, the sodium out, and water follows with it.
That's right. So we remember we got to know the mechanism behind it, right? And it's a lot, right? We're very careful because since it's loop, it's that big loop of Henle, so it opens a huge door. So you're going to release a lot of fluid all at once. So you have to be careful how much you give the person and to tell them when potassium is depleted. Yep, potassium and also aldosterone, all these, like they're affected, right? The salts are affected. So now if a patient is standing up, sitting down, lying down, right? If fluid is affected, right? When you have if this is given for hypertension, yes, we can have hypotension after we give this. And we know with hypotension, if the blood is drained, right, trying to get
orthostatic.
Exactly. Good job, Deanne. Orthostatic hypotension. So, and that's when I sit up, stand up, whatever. So now we imagine then we got to tell them to do it slowly. And if they feel faint, what should they do? Let's say they got up too fast. Like, what do they do? What do they do?
Hold on to a nurse. Hey, call for help. Don't just stand up.
You mean if they faint, or how do you
Yeah, if
prevent
let's
them
say
from
yes,
fainting?
let's say they faint. What would happen?
Well, as soon as they fall down, it would equalize, and they would.
That's it. It's self-solving. But let's say they were feeling faint, but they didn't faint. So what would they do? They would lie back down or put their head. Sometimes they put their head like kind of between their legs to kind of help the blood rush back to their head, right? So the point is you want to get the blood back to the brain, right? Because that's why you're lightheaded. So if you lie down, then the blood rushes back. If you put your head lower than your body, then the blood rushes down, right? I mean, you could stand upside down, but I don't think they'll be strong enough to do that. But all right, good job, guys. Good job. Okay, so let's say, I'm trying to see. Okay, how about this? If I say T wave, what's a T wave?
Is that a twin? I'm sorry, a T wave? Oh, how a wave?
Don't talk about
ventricular relaxing repolarizations of ventricular.
Ventricular repolarization. Yes, Melissa said ventricular repolarization. Janice said ventricular repolarization. That's right. So the ventricles are, what does it mean, ventricular repolarization? What does it mean? What's happening?
It relaxes, it opens up.
Yes, it's allowing blood to accumulate, right? So that it can be pumped out, right? So when we have problems with the repolarization, if the T wave is not happening properly, if ventricles are not relaxing properly, if diastole is not happening, we're going to have problems, right? We're not going to have good cardiac output. Or in order to have good cardiac output, what are we going to have to do in order to get good cardiac output? We're going to have to work faster, harder, right? It's like, if this little bit didn't work, so give me more, so that it can eventually accumulate to the amount that it needs to be, right? All because it didn't have time to really relax, to accumulate, and then give one good stroke, and then the amount goes out that it needs.
Does that mean people getting VTAC in that? That sounds like a VTAC kind of issues.
So it can be a VTAC issue. It sure definitely can, but it could also be it's just the speed of the heart. It could be sinus tachycardia as well, right? Because it's just too fast. Okay. How about sinus bradycardia? What does that mean? What does that tell us? And how could we identify it?
How
too slow. It's under 60.
Under 60, definitely. So we can definitely identify it by looking at our what? If we have a strip, how could we tell? Good job, Elliot.
You have fewer QRS complexes, like your 10-second strip would have less than 6.
That's right. Melissa says it'll be slow. Capital letters. Tuyan says hypotension. Yeah, the person will have hypotension because they're not getting enough blood out. Cardiac output is slower, right? Longer R to R is longer, definitely. The squares are further apart. The range between the two R's are further apart. Good job, guys. How about defibrillation? When I say defibrillation, what comes to mind?
AFib, or I'm sorry, not
Not
VFib.
AFib, not VFib,
VFib, not AFib.
Resetting the cardiac rhythm.
Resetting, I love it, resetting, and we're using electricity to do that, right? Very good. Because, and why do we have to reset it? Why do we have to reset it? Emergency, it's an emergency. We have to reset it because
It restores the normal rhythm.
we have to restore the normal rhythm because they can't remain in that. It's not sustainable, right? VTAC is not sustainable. VFib is not sustainable. Okay. What is it? Whether it's fine or coarse, they can't survive. So we have to restart it. Okay, definitely. And you use a shock. Yep. Good job, guys.
Hello.
Yes, Melissa.
Sorry. I was going to say, is that the precursor to asystole?
It can definitely be. So VTAC is definitely a precursor to asystole because depending, remember if we have not VTAC, VFib is the precursor to asystole. VFib is not VTAC. VTAC leads to VFib, and then VFib leads to asystole if we cannot resolve it. Remember the VFib, the little squiggly lines, you have the fine ones. Eventually, they're just going to stretch out and then be a line. Let's see. The essay node. Tell me about the essay node.
Pacemaker.
Pacemaker, yes. You will need it if it possibly. I mean, no, I'm thinking about a different thing, but yes, it is the pacemaker. It sets the rhythm. What rhythm does it set?
Sinus, normal sinus rhythm.
Which is what?
Atrium.
The atrium to the ventricle to all of that. Yeah. So, but what does that look like? What does that look like?
Normal sinus.
What is normal?
60 to 100 beats per minute.
That's what I'm looking for.
Regular.
You guys are right, but I just needed the numbers, right? Because that would tell us, okay, if it's less than, lower than, then something's wrong with the SA node. If it's not signaling at that, if it's too fast, there's an ectopic, or it's signaling too quickly, or something's wrong with it, right? Where the electrical impulse start, that's the initiator. That is the one that sets the pace, right? So after, what's the next one that's after this one?
AV.
The AV.
And how much does that one signal?
40 to 60.
40 to 60.
And can you survive on that?
Yes.
Yes, you can. Definitely can. Yes. Now, it's once the AV node doesn't work, that's when we're going to have an actual pacemaker. Tell me about an actual pacemaker and why we use it. And how is it, like, what happens when you use a pacemaker?
Well, it sends an electrical current to the rate that it's supposed to be on. And it can be one that is constant, or it can be one that detects when you are missing beats and fills in that gap. And it's sent through a catheter to the node that it needs to trigger.
Oh, definitely. So Melissa says it takes the place of the impaired node. So if the node is not working properly, they'll put a pacemaker in. And I like that you say, Deanne, that it can be a consistent thing, or it can be a supporter. Like it'll be as consistent when, let's say, if you have AV block where they're both disconnected and they don't connect with each other to say which one is sending, like following each other. So then it's going to be consistent because it's definitely broken. Or it can be a little bit of a help where it's like, it works sometimes, it doesn't work sometimes. So then we need, when it doesn't work, it sends a signal. So it could be different ways. So in speaking about that, tell me about capture. What does capture mean? It fires conduction before P wave or QRS. Very good, Soo Young. So, and wait, before I go to the capture, if it's before the P wave, what do we call it?
Atrium pacing.
Yes, and if it's before the QRS, what do we call it?
V pace.
Good job. Okay, so now tell me about capture. What does capture mean?
Well, if it sends its trigger, and then it'll either capture it and show that it's going to have a ventricular response, or if it does not capture, it'll just stay flat.
So if it's captured, that means it reacted, it took in the joules, and it sent the signal, and there is a P or a QRS. If it didn't capture it, we'll see the spike, but then we will not see any reaction, any mechanical movement of the heart. Okay. All right. So tell me, if I say blurred vision, what do you think about?
High blood pressure.
Hypertension?
High blood pressure, yeah. And yes, organ damage. And tell me a little bit about why that organ is being damaged. And we say high blood pressure. Why? What's the connection?
It puts a lot of strain on the intima of the vessels, and then it starts to get damaged and won't move as much. So then it doesn't.
Right. So Trina says retinopathy, right? And so capillary, that's the thing, Suyang. So capillaries are being destroyed, right? And it's just like with diabetes, but it's a little different. Diabetes is for different reasons. So it ruins the blood vessel, and our eyes need our retina. That's how we see. All these blood vessels allow us to see. So if they're being damaged, either there could be swelling, there can be, because the same way, right? When we have edema when we have hypertension, we can have edema in our feet. We can have also edema in our eyes, right? And so when you think about glaucoma, right? What is glaucoma? Glaucoma is high blood pressure in your eyes. And so sometimes they have to go and reduce the pressure. Sometimes those people have to take high blood pressure medication as well to reduce the blood pressure so that it doesn't damage the eyes. And so when the fluid, that vessel is damaged, fluid starts leaking out. And so that fluid is going to start blocking the vision. And so it gets blurred. And so what do we tell the papilla edema? Can't say that word, but thank you, Mariah. For sure, right? We're going to see that cause, so capillary, yep. Okay, so what are we going to tell this person, a person who has hypertension? What are we going to tell them? Since we know they might have blurred vision, what are you going to tell them?
Go see a doctor.
Yes, right. You're going to tell them to routinely see their doctor. Make sure you visit your doctor, get your eyes checked routinely. And why is that? Why is that? Lifestyle changes, definitely. Lower sodium, take your medication. But why do we want to make sure that they see their doctor regularly? What's the key thing? Prevent, right? If they're starting to see blurry, we know they have hypertension. We can start treating it. But imagine, right? When you put pressure, okay, and the example, when you sit on your bum for hours and hours, what happens to it? It becomes numb, right? And then it takes you a while to, even if your foot is like numb or asleep, like it takes you a while to let it work. My point is, and that's because of the pressure that you're sitting on your bum, right? Now imagine that pressure of the fluid is on a nerve, an artery, a blood vessel, anywhere. Eventually, will that space stay alive? No, right? It'll die. So that person will come from blurred vision to blindness. Right? My butt becomes inverted. Okay, Melissa. So then there's the pressure, right? So definitely. So we have Nina says sciatica is real. So true, so true. Okay, so our time is going to be up soon. And let me see if I have any more. Anyone has any questions? Let's see. I didn't do a lot of PVDs. Let me do a little bit of PVD.
Leg up, leg down. A for dangling.
Yeah, I always forget. Thank you, An, right? Mika shared this with me and I was like, oh, I always forget this, right? So V is legs up for what? Valve, and A for arteries, A, leg down. Yeah, dangling. Thank you for sharing that. I'm trying to see if I had any other thing. I don't see my. Oh, no, perfect. Okay, here goes. What is this word? Oh, how about nah, not that one. I'm not really pushing on that one. Oh, this one. Okay, we kind of covered edema, right? We talked about why we have edema. These were all scattered. Okay, here's another one. So, okay, smoking. Tell me about smoking in PAD or PVD. What's the connection? Stop smoking.
Smoking is a vasoconstrictor, like Suyang said.
Vasoconstrictor. Good job, guys. Yep. What else? What about intermittent claudication? What does that mean?
For PAD, they walk and they feel pain, but if they rest, then the pain goes away. So you should tell them like, hey, take a little break, relax a little bit, and then you can walk again.
Yeah, definitely. All right, let's see, what is this one? What about itching? If I say itching,
That's the veins.
that's a
Yeah,
vein.
TBI. Exercise more.
Yeah.
Reverse.
Blood circulation. Let's see. Well, I think that's all I have. I got it. I said edema. What is this? What about the Doppler? What is it? What would we need a Doppler for? If I say Doppler, what does that bring to mind?
4 like to 5 pulses.
When you have PAD.
Yes, right, because there's a problem with the pulses. Yep, that's correct. Let's see. That's all I have, guys. The other things we already mentioned. Let me see. What if I say discoloration?
Okay, that both have discoloration though.
Have
PAD and
discoloration.
TBI.
Yes.
But how do I know though? Like because the discoloration
The
is
veins
TBI.
turn brown.
And then
And rubor for the arteries.
so it rubor, you could think of red, blood cells, right? So in arteries, and then brown is like, okay, the red turned brown because it's dirty. Like, I don't know, that's maybe you could think of it that way if you want to kind of try to remember which one. All right, I think
So the PAD one is like the one with a shiny leg, right? The shiny, smooth, no skin leg, hairless.
correct.
Okay, so if I think of a PAD, I think of a sexy lady. But
Okay. If I say systemic, in relation to perfusion, what are you guys thinking about?
The whole body has the problem.
The whole body, not exactly, but that is
Pain?
true.
Pain, just like pain.
Not pain, but like
Fatigue?
the way the
Fatigue.
nervous system reacts, right? Left heart, no blood flow, too much. No, it's more like when we think of the RAS, right? RAAS, when we think of ADH, or like the reaction or the what is it called? Sympathetic, parasympathetic, how the heart beats fast and the heart rate increases. Like that's when we think about nervous system reaction, right? To blood pressure. Okay.
So systemic is
For
like
moving blood, yes.
body compensating. Okay, compensating for that.
Yes, local versus systemic compensatory. Yes. We're talking about retinopathy. Tell me about the feet. If this goes off, guys, we're done. Okay. And I'll send you the recording because I already see the signal because it's 9:06. So if I say toes and feet ulcers, what are we talking about?
PAD.
For
PAD.
veins, it's on the medial part of the ankle, and for arteries, it's on the feet and the shins.
For sure. Right. And then for both of them, we have to do what kind of care?
Wound care, tissue,
Wound care,
like
tissue care, skin care, right? Making sure it's healthy, it's clean, it's dry, right?
wait. So about wound care thing, I didn't do really well on this part last quarter. So how do you do wound care? Like you wash them, but do you put moisturizer on them?
Well,
But do you keep them dry?
so it's dry, right? They say moisturize, but for the feet, it's dry. And even when you put moisture, you have to make sure there is no wetness, no cream left between the toes, right? But you don't want it to be cracked, right? So then you moisturize to the point of just slightly. But if there's an answer, you're going to pick dry, okay? Clean and dry is what you're going to pick, right? Moisturizing is for like the legs, but moisturizing is not between the toes. Okay. So whatever, medication they give, we're definitely going to apply it. But yes, Melissa is right. Podiatry. Whenever we deal with feet, we don't cut toes. We don't, we allow the podiatry. Same idea with the diabetic. Yes, Su Young, similar to diabetic. Right. Yeah. And you're giving them food and water in order to give them appropriate nutrients for them to heal. You're helping them with circulation. Right. So wound care is really just you following whatever instructions that is on the paper that the doctor decided. It depends on the MD. Correct, Nina. Let's see. Arterial. Who gets hypertension most of everyone?
Black African male.
Yes, African American males. Yep. If I say premature atrial contraction, what is one thing that you can tell me?
PAC.
Yes.
Runs. Yeah, runs. Oh yeah,
You
runs.
might be on a beta blocker.
It might be on the beta blocker. Where is the P? Why is it P? What is it premature? What
The
happened?
atria is contracting prematurely.
Yes, before it should, correct. If I say numbness, is that a good thing or a bad thing? Obviously, it's a bad thing.
Bad thing.
Why do we worry about numbness?
Because it indicates a decrease in circulation,
To what?
usually the feet,
To feed to the nerves, to the nerves.
right, to the nerves.
And so if we have poor circulation to the nerves, eventually we're gonna come from numbness to what?
Ischemia, tissue death,
Paralysis.
necrosis,
Exactly. Right?
paralysis.
I can't feed my feet, I won't be able to walk on it and I might lose it, right? So definitely.
So how do we treat it though? Like if it's a patient come to me and say, hey, I have PAC and I feel kind of numb. As a nurse, what can I tell them? Like, do you want to take
So definitely you're gonna improve circulation because it's because the blood is not getting there. That's why. So we want to make sure the feet remain warm. We want to make sure they are walking, they're circulating. We want to make sure they're staying on their Plavix or aspirin in order to cause the blood to be a little more thinner to get to the extremities. But it's mostly circulation. So the warmth and the movement is the most important thing. And then the medicine is more additional intravenous stuff, right? And then like they're gonna go do a Doppler to see, is there any arteries or veins that are not working properly, arteries that are occluded, veins that are just not functioning. There could be stenosis in the heart, or they're gonna check further to see what caused it to fix it. Okay, if I talk about viscosity, what am I talking about? Blood viscosity.
Yeah, blood thickness, the thickness of the blood.
And what will it affect?
Higher blood pressure. The thicker the blood, the higher the pressure it is.
And if I talk about vessel diameter, what am I talking about?
Vasoconstriction, visual dilation.
Let's check. Okay, let's see. And vessel length. What is vessel? Okay, so we have width, thickness, gangrene, neuropathy, medication that can affect diameter. Yeah, medications definitely can. So vasopressins can affect it. How about vessel length? How does that affect hypertension? Longer the length, higher blood pressure. Definitely. I got to push harder to get to the end of the finish line for sure. If I say secondary or primary, what am I talking about?
Primary, no cause. Secondary, there's a disease cause it.
I'm talking about hypertension for sure. Yeah. So hypertension, primary, definitely like in the onset, we don't know what it is. And secondary, we know what it is. If we could fix that problem, we can get rid of it. But what about hypertension with primary? What do we do there? I know Deanne says out of time. I know, Deanne, we're out of time. All right, so you just fix the symptoms. See you guys. All right, you just fix
it. Love you.
All right, see ya. What is it? Heart. What is this? This thing too.